think that we've let everybody in at this point, and I think we're good to tuck in and get started on today's episode. So thank you everyone for taking the time to join us. Welcome to this really special episode of Connected Conversations, Endometrial Cancer and Obesity. Knowledge is power. And that is the most important part of this day, I think. This is a really important episode to us, and it is a special collaboration between Obesity Canada and the Society of Gynecologic Oncology of Canada. So we have two very special guests with us today, Gia Laurent and Dr. Sarah Sinisak, who are going to help us better understand the links between endometrial cancer and obesity. So I'll introduce them in a bit more detail in a moment, but first you get to hear my regular spiel about Connected Conversations. So for those of you who may not have joined before, Connected Conversation is a monthly series brought to you by Obesity Canada. Each month, we endeavor to have really interesting and engaging conversations where we try and dig into the important topics for people living with obesity and the experts in this field. From advocating to access to evidence-based treatment, issues related to diet culture, weight bias, and discrimination, to innovating obesity care in Canada, our Connected Conversations will address the complexity of this chronic disease and the barriers of individuals living with obesity. Connected Conversations really allows us to create moments of connection for both our healthcare and research audience, and most importantly to me, our patient community. We've absolutely seen the power of making these connections and sharing our stories, and we are very committed to continuing these conversations. So if anyone who doesn't know me, my name is Lisa Schaefer. I am a patient advocate. I'm a member of the patient community. Professionally, I am a marketer and I live out in BC. For the last 5 years, it has been my absolute pleasure to volunteer my time and talent and serve Obesity Canada and working on the public engagement committee, working on advocacy, and really trying to speak up for the millions of Canadians like me who live with this disease that is so highly stigmatized, misunderstood, and quite frankly, really misrepresented as well. So as ever, my sidekick in all these endeavors is Dr. Ian Patton, who is here with us today.
Hi, everyone. Yeah, thanks for joining us today. We are really excited about this webinar and learning more about this topic. I'll keep myself pretty brief right now. I'm the Director of Advocacy and Public Engagement with Obesity Canada. I've been with the organization since I was doing my graduate work in 2008. So I volunteered and was a student in training for many years. And now I have the privilege of being able to kind of tie that passion and work I did in my education into and as well as my lived experience into the work that I get to do now. So really happy to be able to do these webinars with Lisa and the rest of the work that I do with Obesity Canada. So a little bit of housekeeping for today for the webinar. As always, you can utilize the chat and make sure you let us know where you're coming from. You can continue the conversation on in there. If you have any questions for the webinar today, you can include that in the Q&A feature. You're allowed to upvote those. So if you see a question that you like, you can always upvote that and it'll jump up to the top. So it'll be easier for us to manage that. And I think that's about it. I'll leave it at that for now.
That sounds great. And yeah, I definitely think this one is going to have legs. So feel free to chime in on the chat or in the question and answer, as Ian said, because I feel like this is one that's going to be a conversation that will absolutely continue. But let's tuck in and talk about this. Endometrial cancer and obesity. Knowledge is power. Dr. Sinisak is a gynecologic oncologist at the Ottawa Hospital and assistant professor at the University of Ottawa. She has completed residency in obstetrics and gynecology and a fellowship in gynecologic oncology at the University of Toronto. She has a master's degree in public health from Harvard University. She is the Gynecologic Oncology Fellowship Program Director at the University of Ottawa. She is the chair of the Education Committee at the GOC and the founder and co-chair of the Community of Practice in Obesity. She has extensive training and experience in advanced laparoscopic surgery and has an interest in surgical skills education. She's one of the good ones. So we'll let you introduce yourself as well in a moment, but I will also take a second and introduce you to our second panelist today, Gia Laurent. Gia is someone who has lived experience with endometrial cancer and also experienced the crossroads of this diagnosis with obesity. Gia has been brave enough to share her experience with bias and stigma in healthcare and has been raising awareness so that others can get the care they need and deserve. And she has a fantastic blog. We'll make sure that we share in the chat as well. So welcome to you both. Thank you so much for joining us today.
Thank you for having us.
Yay, this is going to be a good one. So as we said at the top, we think this is a really important topic. We think this is a really important partnership as well. And as the title of the episode suggests, knowledge is power. So we really want to raise awareness. We want to transfer knowledge today. We know a great way to do that and make it sticky is with lived experience. So we really hope that we can raise awareness through this conversation today. Also talk about those preventative measures and early detection pieces so that everybody can get effective treatment. But I think the context of starting with your story, Gia, would really be fantastic. So if you could introduce yourself a little bit and maybe share that lived experience, let's start there today.
Of course. Thank you so much, Lisa and Ian, for having me today. I am a writer and podcaster. I am a strong advocate in mental health and mental health awareness. I've been living with obesity for most of my adult life. It didn't start out that way, but it is where I'm at currently. I was recently diagnosed. I was diagnosed with endometrial cancer in July of 2021. And through several operations that were successful, I am cancer-free today with incredible assistance and love from everyone from St. Michael's Hospital. I was able to get through it. It's difficult for me because I suffer from anxiety and depression, also an eating disorder. I have, again, for most of my life, and I have health anxiety. So it's not easy for me to get to a doctor necessarily. If something is wrong, I alarm myself, but I don't seek medical attention right away. I try to just live with it and move forward. Again, it's just my anxiety, and it's always been that way. I haven't really trusted the health community to help me. Whenever I did find or muster up the courage to, contact my doctor about something, my weight was always the main focal point of the discussion. And although I am fully aware and fully on board with the fact that health is first and foremost in anything, and weight has a lot to do with that. It always took center stage when it didn't have to. And even though that conversation, needs to be had between doctor and patient, it was done with me. It was done in just an uncaring, bullying, biased way.
And that's something that we hear a lot in our community as well, is that experience of trying to navigate healthcare, whether it's I've just got a broken arm or I want to talk about something, I have a problem with my ear. If you go and all you ever hear is that conversation about weight, which may sound very overinflated, but I know from my firsthand experience that it is very true. How often you can go to seek attention for something completely different, and that still took center stage, as you said as well. It's something that we hear a lot. And I was sharing with Gia earlier as well, we've heard from other advocates globally. And we have a really dear friend who shared her lived experience as well with, the first time she went to go have a pap or an internal, which is already an intimidating moment for a woman. I don't care what body you are in. Yeah. That's an intimidating moment when you are, especially if you're a teenager and you're, it's awkward. It's awkward to start with, let alone if you're in a bigger body. And this advocate shared her story of the first time she went, they told her that the table would not be able to support her. And could she just lie down on the ground for them? How likely are you to go back if that is the experience you have?
How likely are you able to finish that exam alone in that moment in time?
Yes. And how attentive are you in hearing what's being told to you in that moment, whether or not it's just standard health health information, or if it's something really important. That's something that I took from reading your blog as well. And I know your diagnosis was a big one, but it's so true in that moment when you're trying to listen and pay attention to what doctors are saying. But if you're already feeling like you got your elbows up, or you have to be defensive, or that you've already been treated like you're this important, it's a challenge. It is
Absolutely.
a big challenge for sure.
Absolutely. And in my particular case, again, it was continual mustering up of courage on my end to kind of repeatedly go back to my doctor. I'm 48 now. When I was approaching my 40s, I noticed that my period started getting, different, more painful. The symptoms were just unbearable sometimes. And going back, there was never really any kind of assistance, for lack of a better word. It was just, you're heavy. This is why you're getting the excessive bleeding more so than not. This is why this is happening. And, if you lost some weight, this would not be the case. And well, you know how my story went.
Yeah. It is a lot. So can I ask, one of the things when I read your blog as well, I believe you were diagnosed with endometriosis as well. Is that something that you were diagnosed with earlier in life, or was it also in this moment that you found out about the endometriosis?
It all came at once. As I said, when I went to speak to my doctor about it years ago, basically it was just, you're getting into the later years of your life, perimenopausal, things look different. She never sent me to a professional or a specialist, never sent me for tests. Now, because I have that health anxiety, I thought, okay, I'm not going to push the envelope. I've mentioned it. If she doesn't seem concerned, I'm not going to be. I had anemia, basically diagnosed anemia because of the loss of blood that I was continuously experiencing. And she, basically threw some iron pills my way and, just deal with it. This is something that's going to happen. It's going to be changing. The patterns will be changing. Everyone experiences it. It's not a big deal. And in the meantime, lose weight. So it wasn't until February of 2021, I started experiencing pain just after a period. My period had left in 2-3 days, and all of a sudden I had this massive pain in my abdomen area for no reason. I was fine, perfectly fine before. I collapsed on my kitchen floor as I was making dinner, and I was rushed to the hospital. And that's kind of where it all began, where they found masses inside of my body. They told me that obviously after testing, I had endometriosis, and that there was, a further biopsy that needed to be done.
That is a lot to navigate all in one go.
Yeah.
That is big.
Yeah.
And I think one of the other pieces that I kind of reflected on when I was reading some of your story as well is, and I've tried to articulate this along the way when talking about my own journey, is to a degree the distraction of diet culture, the misunderstanding of obesity as a disease, and or these constant conversations with doctors that are focused on weight loss in particular, like that's going to be a cure-all, really distanced me from my own body and my own body wisdom, if that makes any sense, as well, because you feel like you're incorrectly human is the way that I phrase it. So that I must be, okay, like to your point, if they're not worried, I shouldn't be worried. But in reality, we are in charge of our bodies, and we should be so attuned to our bodies, and we should be the strongest advocate for our bodies. But that's such not the moment that I think many of us in larger bodies, let alone women in larger bodies,
yes,
really see themselves or even know how to be that, which is why I love being a loud lady, because I would happily show other ladies how to be loud. Is part of my world. But does that connect in your head a little bit too about that disconnection
Absolutely.
from your own and trusting your own gut?
Absolutely. I was always made to feel ashamed. I felt embarrassed in situations and very self-conscious all the time, generally in my own head and in my own life. When I went to a doctor, I felt like I I wasn't given the same care. I wasn't, I shouldn't have been categorized like everyone else. I wasn't able to get the same kind of care. And that advocating for myself was nothing, I never thought about it because I was just always felt timid and shy in a doctor's office. I've always been made to feel like I wasn't worthy of medical attention because of my size and because of what my body looked like. So, you know,
it's too much. All right, Dr. Sinisak, I'm gonna bring you in, Coach.
Okay.
Does that reflect your experience as well of kind of what you've seen come through the door from the physician side? Does that connect in your brain about people being kind of defensive or not able to advocate for themselves a little bit? Do you have any take on that?
Yeah, absolutely. I think so. We'll kind of get into this in my portion of the talk, but a lot of my patients, in addition to having a gynecologic cancer, also have live in larger bodies, have higher BMIs, or have obesity as a medical condition. And so we do see that a lot. And it's not uncommon that I hear this story that Gia is telling, where they sought care and were having abnormal bleeding, we're having, particularly when it's in the premenopause, like yourself, Gia, where vaginal bleeding is still a normal part of life to a certain extent, but having very heavy bleeding or very irregular bleeding is not normal, and patients feeling that those issues were not addressed in the way that they might have hoped. So yes, it's unfortunately a common story.
Heartbreaking. And I know part of my story that I've shared along the way as well is that I feel like I was tested for PCOS or all of these different things, and it was never came back as that was the issue. So then I was left as like a 14-year-old going, okay, well then I'm the problem. And I'm also need to figure out how to fix this.
Yeah.
And that wasn't just, my body size. I was very similar. I had very irregular periods my whole life. I basically feel like I was told since the age of 15 to just not plan on having kids. Like, that's a lot. And I think that we need to really help women understand this moment that they can demand for better care and better conversations even. I think, Gia, you and I touched on that, like just the difference that you felt when you got to practitioners that really listened and changed the experience for you. Just even understanding that there is a different experience that you can expect in a healthcare setting is huge.
Yes.
Oh, this is really big.
Yeah.
So can you connect for us what that looked like? I know I've read your blog, Gia, but maybe if you can just share with people a little bit so you collapsed, then you were diagnosed, then what did it look like from there? And how did you get to feeling more empowered and being able to advocate for yourself?
So when I first arrived at the hospital, obviously the last thing I thought about was cancer. I didn't think that was the end result for me. Or the end diagnosis. I knew that I was dealing with endometriosis. I had an infection, which is why I had collapsed. All of those masses in my body were infected. And that's what they initially treated. After the biopsy, or actually before the biopsy, I met a wonderful lady by the name of Dr. Andrea Simpson from St. Michael's Hospital. We had some appointments set up. She immediately made me feel at ease and said that she would, we would get to the bottom of it together. The biopsy came, and that's when I got diagnosed, was in July of last year. And I know that people, you see people go through it on TV and you hear about it and, on social media and so forth, the people telling their story about cancer, but it literally, like, the bottom of the floor opened up and swallowed me whole. I never thought in a million years that would be me, even though I wasn't a great advocacy for my own health because I was so afraid of everything. I just didn't think that was what I was facing. But thankfully, again, my outcome was fantastic, and it just made me feel, the whole experience, I feel like if I had to go through it, I'm happy that I had the experiences that I did. So today I'm able to advocate for myself I, like you, am a very loud woman now in regards to what is going on for me. And the quality of care that I received, I now know is absolutely what I deserve, regardless of what my body looks like. There were periods of time, the old me, had very heavy eating disorder issues, because when I was told by my doctor, you just have a lot of weight to lose. There's no way that you're going to do it the old fashioned way by, eating well and working out like everyone else. Save your money and go get some plastic surgery, or, go get a gastric bypass surgery. That is your only hope at this point. And my initial reaction was I cried for the entire weekend. And then I thought, you know what? No, I'm going to prove her wrong. And I did everything humanly possible that was unhealthy to lose as much weight as possible, to go back and show her, will you listen to me now that I have dropped 100 pounds? Will you listen to me now? But I did it in such a drastic way. And if anything, it just brought on more issues. My relationship with food completely destroyed. My relationship with my body completely destroyed. And it wasn't until I was treated like a human, and taught, this is what's going on in your body. This is why you've been experiencing what you've been experiencing. Now we know everything that we're dealing with, and it is endometrial cancer. This is the stage it's in. This is what we're going to do for you. And we're going to do our best to, help save your life, basically. And, moving forward, it didn't stop there. After my surgeries were done, I'm sure you read in my blog, it was almost a near-death experience. I had large complications with my last surgery. I didn't think I was going to make it. And I remember promising my doctor, I thought, because you saved my life and you helped me, and you helped me understand that I deserve a better quality of life and I deserve more, I'm going to take this and run with it and change my life. And I did. And I've, since the surgery and since the recovery, it's been, I guess, since January of this year, I've lost 35, 40 pounds. I have completely, been in therapy, and just changed my relationship with myself and with my doctors. I've since interviewed for a medical practitioner. And I know it sounds silly to say interviewed, but, I interviewed different people. I wanted to make sure that I was in the best hands possible for what I was going through on a day-to-day. And I wanted to make sure that they were going to deal with my mental health and just me as a person, and the obesity side of things. So
thank you so much for sharing all of your story. I mean, it really is the thing that I think is going to help everyone move forward. But I don't want to distract or lose the fact that we really do. I mean, endometrial cancer is big. It is a problem. It is, or not, I shouldn't say it is a problem, but it is a prolific thing that I also want to give good attention to and good conversation to. So I would love, Dr. Sinisak, if you can help us connect the dots a little bit more, understand that endometrial cancer side of it, and how the relation to obesity kind of comes into play, how it might have been like reflecting on Gia's story, but then sharing with everybody else so that you can kind of be more aware, because I think early detection is a big part of this conversation too.
Yeah, absolutely. So is now a good time for me to start sharing my
Absolutely.
slides?
Yeah. I know you've got a few slides and stuff. Let's go there. Let's teach people some new things today too.
Yeah, exactly. So, I'm a physician. We like PowerPoint presentations. So hopefully that's okay with everybody. Give me a second here.
All good.
Go. So, can everybody see that? I'll put it into presentation mode.
And as a reminder, as we're moving through, if you do have questions, feel free to pop those in the Q&A box as well.
Yes, absolutely.
All right.
And I don't know if I can see the chat in presenter mode. So
no worries. We'll shout it out if there's anything good that we need to.
I'll take care of that.
Perfect. So I'll just introduce myself a little more initially, and I'd be curious to know who our audience is. Just I created this presentation mainly for a general public audience, but I can certainly get into more detail if there are clinicians or other physicians in the audience. So happy to adjust as needed.
Yeah, typically the audience is a bit mixed. We'll have people from our public community, but we'll also have people from our professional community. So we probably have a mixed audience.
Okay, great. So hopefully this kind of works for both. So I'm Sarah Sinasak. I'm a gynecologic oncologist in Ottawa. So just to sort of, for those of you who may or may not know what a gynecologic oncologist is, because it is a fairly small subspecialty of gynecology. I am a surgeon who treats gynecologic cancers like endometrial cancer, ovarian cancer, cervical cancer. Unique to our specialty, we, in addition to being surgeons, we also give chemotherapy and other medical treatments for cancer. So that's kind of my scope of practice. And one of my areas of interest is this intersection between obesity and gynecologic cancers. And so through the GOC, which is our national body of gynecologic oncology providers, myself and Dr. Simpson and Dr. Bernard, who I see is on here, we are, and a number of other of our colleagues are involved in a community of practice on obesity to sort of see how we can optimize care for patients who have both obesity and gynecologic cancers. So that's how I ended up here, and I'm so pleased that we have been able to partner with Obesity Canada for this talk. So, you know, I'm not trained as an obesity medicine specialist. I'm trained obviously as a gynecologic cancer specialist, but because of my interest, I end up, you know, attending a lot of webinars myself, listening to podcasts and educating myself about obesity as a medical condition and its management. And so as I'm listening to a lot of these talks, you know, once in a while you hear obesity medicine specialists talk about this association between obesity and cancer. But one thing that I have noticed pretty consistently is that despite the strong association between obesity and endometrial cancer specifically is almost never mentioned. So I feel like there is a real missed opportunity there because, and we'll get to this in a little more detail, but endometrial cancer can be prevented, it can be treated and is highly curable in early stages. So the more awareness we have, you know, there really is a lot of hope in this disease. So I'm very grateful to be able to talk about this in a little more detail. So the key takeaway points that I wanted to get at, as have been mentioned, endometrial cancer is very common and it's on the rise. Obesity is a risk factor. There are effective prevention strategies available. It can be detected early. It's often curable, and young women may be candidates for fertility-sparing treatments. So,
can I ask a question about that for one sec? When we say fertility-sparing treatments, can you just unpack that and make it for my brain a little bit?
Oh yeah, for sure. So for women who are younger and diagnosed with endometrial cancer who may still want to go on to have future pregnancies, there are medical treatments other than hysterectomy that we can offer some patients to try and allow them to have a pregnancy in the future once their cancer is treated.
Thank you.
Yeah. Sorry, please stop me if any of the medical jargon gets in the way. So our group put together an endometrial cancer awareness campaign with the support of Obesity Canada. It's available on the GOC website, and the link is here, and hopefully we can provide everybody with that link as well. A lot of the information on the website will be presented today, but if you wanted to look at it in further detail, it's all there. So this is kind of the first slide on the website, which again is just reiterating some of the things that I just mentioned. And really we wanted this this website and this campaign to be, again, empowering and positive and giving people information that they need to take control over their own health. So I think this is really important data to talk about on this slide, and I'll take you through it because it's a little busy, but endometrial cancer is really an outlier in terms of malignancies in Canada. So if we look at the most recent Canadian cancer statistics from 2019, what you're seeing here with these different colored lines, and I don't know if let me see how I can use the pointer here. So each of these lines represents a different cancer. So, so this one is lung, this one is breast, this one's colorectal. And what you can see is that for most of these slopes over the past decade or so, these represent mortality from these different cancers over time. So most cancers in Canada, mortality is decreasing over the last decade. Some cancers, like pancreatic cancer, are unfortunately staying stable. But this black line here is endometrial cancer. And endometrial cancer is the only cancer in Canada with a rising mortality in recent years. So this is one of the key reasons that I think we need to be paying more attention to endometrial cancer and making people more aware of this disease and its signs and symptoms and how to seek treatment. So as we mentioned, the most the strongest risk factor is really obesity. So having excess body fat can increase your risk for endometrial cancer by 3 to 10-fold. And we describe this as what we call a dose response relationship. So meaning the higher your BMI, and I realize BMI is an imperfect measure of body fat, but the higher your BMI, the higher your risk of getting an endometrial cancer. So there is a strong association there. In addition, we see an association with other conditions that are also associated with obesity. So things like diabetes, PCOS, which can be related to infrequent periods or what we call anovulation, not ovulating regularly. It's also associated with older age. Other risk factors can be things like use of tamoxifen, which is a treatment for breast cancer, other hormonal therapies. And there are some genetic syndromes, in particular Lynch syndrome, that can increase your risk for endometrial cancer as well. So in trying to understand why is obesity and its associated conditions such a strong risk factor for endometrial cancer, and the way that we can understand that is really by looking at what is the cause of endometrial cancer. And the cause of endometrial cancer is really based in a hormonal imbalance. In particular, it's an imbalance in estrogen in relation to progesterone. So estrogen and progesterone are obviously normal hormones in our bodies. They normally cycle each month as we go through our monthly cycle with ovulation. Estrogen increases and causes the lining of the uterus to thicken and to grow. And then after ovulation, progesterone gets released and becomes quite high and keeps that growth of the endometrium in check. So conditions that cause an imbalance of these two hormones can increase the risk of endometrial cancer because the lining, the growth of the lining of the uterus is no longer controlled or regulated. So what we think about is really what we call this environment of unopposed estrogen, meaning too much estrogen in relation to progesterone. So how do we get too much estrogen? How does this situation occur? So peripheral fat cells in the body contain an enzyme called aromatase. Aromatase converts androgens, or male hormones, which exist in people with female bodies as well, to estrogens. So the more fat cells you have in your body, the more estrogen you have that's actually being created peripherally, not just by the ovaries, but by your peripheral fat cells as well. This leads to that hormonal imbalance, which can then impact your ability to ovulate regularly, which then further decreases the amount of progesterone around because you only really get a surge of progesterone after ovulation. In addition, the more fat cells that you have, the more likely you are to have insulin resistance or higher levels of insulin in the body, called hyperinsulinemia, or too much insulin. Insulin is also a growth factor. So insulin also drives growth of the endometrial lining. All of these things can cause changes in other molecules in the body, like sex hormone binding globulin, which usually pulls estrogen out of the blood. And what you get, which you can kind of see with this nice little image here, is all of these things lead to this ongoing stimulation of the lining of the endometrial cavity. And when that occurs for a long period of time, over many, many years, you can eventually get what's called endometrial hyperplasia, which is a precancerous change in the lining of the uterus. And over time, these cells, because they're growing and turning over again and again, accumulate genetic damage and can eventually develop into a cancer. So that's, in general, how we understand this, how these two conditions are so strongly linked. Now, don't get overwhelmed with this image, but this is basically just summarizing this very complex hormonal environment. So it's all these hormones interacting together on the endometrial lining, summarized by too much insulin, too much estrogen, and chronic inflammation, all of which can lead to tumor development in the lining of the uterus. So if we look at the association between obesity and cancer, we see that a number of cancers are associated with obesity. So if we look at the risk of all cancers, it's about a 2-fold increase in association with a BMI over 40. And then we can go down here and see, look at some other cancers like esophageal cancer, 2.5 times, pancreatic cancer, almost 3 times. This is endometrial cancer. So wow. An almost 6-fold increase in risk. So it really is this outlier that has a very strong association with high BMI. Sorry, I just realized my computer is unplugged and I'm just gonna plug it in before.
No problem.
Run into a problem. Second.
That chart is impactful to show how much more we're talking about in that uterus cancer.
Right. Not to get too technical, but I think that some of that data really demonstrates how strong this association is. So what are the symptoms of endometrial cancer? What can we look out for? So I think, Gia, your story really highlighted this really, really well. So in general, the first symptom of endometrial cancer, whether it's in the premenopause or in the postmenopause, is some type of abnormal vaginal bleeding. I think this can be tough for people because for a lot of people with uteruses, vaginal bleeding is a normal part of life, right? And so it can be hard to know when is vaginal bleeding not normal, when does it cross that threshold. So certainly we know that any vaginal bleeding after menopause, which we call postmenopausal bleeding, is never normal. We'll get into the definition of that. And then abnormally heavy periods in younger people is also something that we need to be on the lookout for, particularly if you have other risk factors for endometrial cancer. So premenopausal endometrial cancer is more common than you might think. So up to 30% of endometrial cancers occur in premenopausal women. And that percentage is on the rise as people live in larger bodies from an earlier and earlier age. That exposure to that hormonal environment we just talked about starts at a younger age. And so we're seeing the problems associated with that happening at earlier ages. The youngest patient I have with endometrial cancer is 22 years old. That's not very common, but I do have a number of patients in their 30s and 40s with endometrial cancer. So what does abnormal mean? What is an abnormal period? So periods more than 38 days apart. So really long periods of time between the first day of one period to the first day of the next period. Your periods are so heavy that they're interfering with your health, your well-being, or your quality of life, or you're having symptoms of anemia. Gia, you mentioned this. You're feeling dizzy, lightheaded, you feel fatigued all the time, signs of anemia. That's certainly something you should see your doctor about and that your doctor should investigate further. If your periods last more than 8 days, especially if they're spaced out, you have random bleeding between your periods, so things are all over the place, there's no pattern, or if your doctor has prescribed medical or hormonal treatments and it's not working. So all of those things would be sort of red flags to say, okay, we need to investigate things further. Now, what could be the potential causes? So heavy or abnormal bleeding in premenopausal women, cancer is not the most common cause of that, but it's certainly the most important cause that we want to rule out and make sure it's not that before we move on and try and treat something else. So it can be caused by other things like, polyps, fibroids, infection, precancer or cancer of the cervix. These are all things we want to rule out, but cancer of the lining of the uterus and endometrial cancer is a really important cause to rule out in this process as well. And we'll talk about how we do that. I forgot to highlight our images from our nice images from our awareness campaign. So if your periods feel like a flood, that is not normal. So talk to your doctor about an endometrial biopsy. So this is our image for the postmenopausal women. So bleeding after menopause is never normal. So if you're in menopause and going to the menstrual products aisle, that should be a red flag to call your doctor. So what is menopause? So menopause is going 12 consecutive months without having any vaginal bleeding. That puts you into the definition of menopause. Any bleeding after that time would be considered postmenopausal bleeding. The average age of menopause is 51. So I would sort of say, although there is a range of the normal age for menopause, I have patients coming to me not infrequently who are 57, 58, and I say, when did you go through menopause? And they said, oh, well, I never stopped bleeding. I've been bleeding this whole time. So if you're well above the age of natural menopause and still having bleeding, that should also be a red flag that your doctor needs to look into. So what are the causes of postmenopausal bleeding? So similarly, the most common cause of postmenopausal bleeding is not cancer. It's what we call atrophy or thinning of the lining of the uterus or vagina that can cause bleeding. But certainly precancer or cancer of the endometrium is definitely something that we want to rule out and make sure is not the cause. So if you have abnormal bleeding or you have postmenopausal bleeding and you go to your doctor, what would be the next steps, or what is the most important thing that your doctor should do to rule out endometrial cancer? And that test is called an endometrial biopsy. So an endometrial biopsy is a procedure that's done in an office, not under anesthesia. It's just similar to getting a pap test. A speculum is placed in the vagina. We take a look at the cervix. We take a thin straw called a pipelle. It's plastic. It's quite bendable, it's soft, and there's a little tiny plunger inside that allows us to pass that straw through the cervix into the lining of the uterus, into the endometrial cavity here. And then we pull back the plunger to create a little bit of suction, and then we just rotate this pipelle around, and it samples takes a sample of cells from the lining of the uterus, which then go into this straw. We pull it out, and we send the cells off to the lab for the pathologist to look at under the microscope. It is uncomfortable. Yeah, I'm sure you had one done. Maybe you can tell us what that experience was like. We tend to tell people it feels like really bad menstrual cramps for a few seconds. Some people tolerate it really well. For some people, it's extremely painful. But for most people, it seems to pass fairly quickly. If for whatever reason this can't be done in the office, the other option is to take patients to the operating room for a DNC under general anesthesia, or to put a camera inside the uterus called a hysteroscope and take a sample back. We don't use anesthesia in the office, mainly because it doesn't really tend to work. Some people try putting freezing in the cervix, for example. It doesn't tend to make that crampy menstrual like feeling any better, so we tend not to do it. So that is the diagnostic procedure. In addition, your doctor may order an ultrasound of the pelvis just to look at the size and the shape of the uterus, check the ovaries. But the main thing that you need is the biopsy to rule out the cancer.
Do you remember that moment, having to navigate that moment?
Yeah, I'm having PTSI at this point. I actually had a specialist attempt to do this in their office. It was too painful. We couldn't even complete it. And that's when I had it done. I had several different things happening, but the biopsy was one of the things that I had through my first operational thing. But I had to be put under, I couldn't do it.
Yes, and that is the case sometimes.
Yeah.
Okay, so before I get into treatment, I wanted to talk a bit about the prevention side of things. So because we can identify people who have risk factors for endometrial cancer, we want to be able to highlight for those individuals things that they can do to potentially decrease their risk or prevent an endometrial cancer. So this is the list of things we have on our website. So first of all, increasing physical activity levels. And I think this point is really getting at trying to increase insulin sensitivity, decrease that hyperinsulinemia state. Maintaining a healthy weight, which is obviously easier said than done. So I want to talk about that a little more on my next slide. So I'm just going to skip over that briefly. The next point is treatments that can correct the hormonal imbalance. And I think this is a really important point that I'd like to drive home a little bit. So because, of course, getting to a healthy weight is not something that happens overnight, I think it's important to be able to offer people treatments to correct this hormonal imbalance in the meantime, while they're working on all of those other health conditions. So options would include things like the birth control pill. So the birth control pill contains both estrogen and progesterone. And what it does is it kind of takes over from the ovaries and provides the body with the correct balance of estrogen in relation to progesterone. So that can be helpful, particularly for younger women who maybe have really irregular periods, who haven't been getting a period for months at a time and then have a really big flood of a period, things like that. The birth control pill can be a good option in that situation. My favorite option, both for my patients for a number of reasons, is something else called an intrauterine device, an IUD that actually releases progesterone locally into the uterine cavity. It's a little plastic device that's inserted in the office into the uterus. It can be used for contraception. It can be used to treat heavy periods. And it can be used in postmenopausal women who have no bleeding at all, but who might be at increased risk for endometrial cancer. And, used in any of these contexts, it has been shown to significantly decrease the risk of developing endometrial cancer. And what it does is it's basically protecting the lining of your uterus by providing the endometrium with that progesterone that's deficient in the body. And so while you're, sort of working on all of the other health issues that will be important for your overall health, doing something like this, which this IUD can be put in a few minutes in the clinic. It can stay in the uterus for 5 years, or even up to 7 years or longer, and provide you with really good endometrial protection and decrease your risk for endometrial cancer. So it's not a magic pill. People can still get an endometrial cancer with a progesterone releasing IUD, but the risk of that cancer has been getting that cancer can be significantly reduced.
That is so interesting.
Yeah. So, and I think this is something that is being really underutilized.
Mm-hmm.
So this is something that we as a group really want to make people, make individuals more aware of, individuals who have risk factors so they can ask for it, and also make clinicians more aware of it so that they can offer it to patients.
I was 100% team IUD already. And now that I know that this is a preventative measure, I am going to get loud about this as well.
Oh, that would be great, Lisa.
It was such a game changer for me. And I was actually, sorry, not that we need to talk about me and my uterus, but when I made the switch, I was like, why wasn't this introduced to me in my 20s? This would have been a game changer in my life on so many levels. This is fascinating.
Absolutely.
Sorry.
So yeah, as a contraceptive method, It is the most common form of contraception used by physicians for themselves, like as for their own contraception. So that tells you something. Game changer in terms of preventing people in the perimenopause from needing hysterectomies from abdominal bleeding. And then, yeah, it has this other really beneficial effect in terms of decreasing the risk of endometrial cancer in people who might be at risk. So I think that's something we need to talk about a lot more. So getting back to the maintaining a healthy weight note. So, you know, my caveat is that I am not an obesity medicine specialist. I try to refer all of my patients who are interested to people who are obesity medicine specialists and who work in multidisciplinary clinics who can provide the appropriate medical care for the hormonal imbalances that exist, who can provide options for medications that might be helpful for weight loss, who can provide nutritional counseling and coaching, who can provide the psychological support, cognitive behavioral therapy, things that can promote behavior change. All of these things are tools that people can use, and some tools might be right for certain people, and some tools might not be. One of those tools is also bariatric surgery, and it's not for everybody, but it is one of the tools in the toolbox. So the reason why I bring up this slide is simply because it's a really nice demonstration of a population of patients who had an intervention that allowed them to lose a significant amount of weight and sustain it for a long period of time. So this study is the Swedish obese subjects study. There were two groups of patients. One had bariatric surgery, one had usual care, and they've been followed for over 2 decades now. So this data has been looked at for a lot of different medical conditions, and one publication back in 2017 looked at cancer risk in this population 2 decades after the bariatric surgery. So in this population, on average, people lost 20 kilos, which was sustained over 15 years. That's an approximation of that data. When we look at the cancer risk in the entire population, cancer risk was decreased, but for women only. So in the male population, cancer risk was not decreased after bariatric surgery. And then when we further break down the cancer data among women, we see that this decrease in cancer risk was very strongly driven by the decrease in endometrial cancer. So if we look at cumulative incidence of cancer events in women in this population, in the group of people who essentially maintain stable weight over those 20 years, this blue line represents the number of cancers diagnosed in that population. And this orange line represents the number of cancers diagnosed in the women who had bariatric surgery and were able to maintain on average a 20 kilo weight loss over 15 years. So I say this not to advocate for bariatric surgery. That's not the point of what I'm saying. What I'm saying is for people who are able to maintain a significant weight loss over a couple of decades, we do see that this is associated with a decrease in the risk for endometrial cancer. So whether you do that through a plurality of different interventions, not necessarily bariatric surgery, we would expect to see a similar reduction in risk.
I'm just going to jump in here. I have a quick question that I want to throw out while we're talking about this, but I think this is really interesting information that you're sharing with us here. And I think with the advancement that we've seen in the last 10 or so years with obesity treatment and our better understanding of obesity management that we've been working on, I think it'd be interesting to see if similar type of results would be seen with other treatment modalities for obesity. And I think that's important data that we should be looking for. So this is sparking some interest for me here, but there was a question for you, Dr. Sinisak, that I think we can tie in here, and it's specifically about the relationship between endometrial cancer risk and obesity. Is there a relationship with waist circumference independent of BMI, or are we aware of anything like that where independent of BMI some of those other indicators for higher weight or obesity, would they be related with endometrial cancer?
Yeah, for sure. I think so. Waist circumference is a marker of metabolic syndrome, and so anything that's indicating a metabolic syndrome picture, which can be obesity, central obesity, hypertension, PCOS, diabetes, hyperinsulinemia, all of these kind of linked conditions are certainly a risk, are certainly associated with endometrial cancer, increased risk for endometrial cancer. It's an important point to note because in certain ethnic populations, we can see more hyperinsulinemia or increased risk for things like anovulation, PCOS at lower BMIs. So as I said, BMI is a really imperfect measure of this complex hormonal environment, but waist circumference is one way of getting at that more metabolic syndrome picture in some individuals as compared to others. Yeah, it's a really good point. And I'm really interested in your point too, because as I said, I'm not an obesity medicine specialist, but the more I learn about the advances made in medical therapies for obesity management in the past number of years, it's really exciting to think that maybe some of this decrease in risk can be seen without having to go through a major surgery like bariatric surgery.
Well, and I think you said it the right way, where bariatric surgery is one tool in that toolbox, and we are gradually getting more and more tools in that toolbox, and sometimes we're figuring out that combination of those tools is important for long-term obesity management. So for some, like you mentioned, bariatric surgery might not be the right choice for them, but for some it might be bariatric surgery plus other things, whether it's cognitive behavioral therapy or other things that, there's other tools in that toolbox. So it's interesting.
Yeah, absolutely. And I think it's important for physicians that we realize everybody's an individual, right? So what works for one patient might not work for another patient. What feels comfortable for one patient might not feel comfortable for another patient. So I think that's a big component of how we think about this, that we can't just think that everybody's going to respond to the same interventions in the same way.
Yeah.
Okay, so how do we treat endometrial cancer? So we mentioned at the beginning fertility sparing surgery, and thanks Lisa for clarifying that. So basically what that means is for younger people diagnosed with endometrial cancer, if it's diagnosed at an early stage and it's what we call a low grade cancer. So lots of people get confused about grade and stage. The way I explain it to my patients is that stage is where the cancer is located and grade is what the cancer cells look like under the microscope. So basically, if you have all the good factors, meaning it's early stage and low grade, which is in fact the most common kind of endometrial cancer, you may be a candidate for treatment with medical therapy without removing the uterus. And the idea of this is to reverse the cancer changes under close medical supervision. So we have to do regular biopsies every few months to make sure that the cancer is responding to treatment. But in a large proportion of patients, we can see a complete response, meaning that those cancer cells go back to normal cells for a period of time, allowing people to have a pregnancy. The treatment in the past was often oral progesterone, high dose oral progesterone, again, to correct that hormonal imbalance. The problem with oral progesterone, it works really well on the cancer. The problem is the side effects are really intolerable for a lot of people. One of the main side effects is that it causes increased appetite and weight gain. So that in and of itself is not being very helpful to the overall health and well-being of the patient. So it is not my preferred treatment of choice. Again, my preferred treatment of choice is this IUD that releases the progesterone locally into the uterus. So not only can that IUD prevent cancers in people who are at risk, but it can also treat early stage low grade cancers in some individuals. For most women with endometrial cancer, however, the first step in treatment is surgery. And what that involves is a hysterectomy, so taking out the uterus, the cervix, the tubes, and the ovaries. Often this will involve a sampling of the lymph nodes. The most common thing that we do now is called a sentinel node biopsy, where we inject some dye into the cervix when you're completely anesthetized in the operating room, and the dye travels to the most important lymph nodes in the pelvis and take out just those lymph nodes that light up with this fluorescent green dye that we use. It's very cool. So this can be done, most commonly it's done either laparoscopically or robotically. Those are minimally invasive surgeries where the incisions in the belly, you have typically 4 incisions that one is a centimeter and the other 3 are 5 millimeters. So they're all very, very tiny. It's usually either a day surgery or an overnight surgery. So you would go home a few hours after your surgery or the next morning. If your uterus is a bit larger, or if you've had a lot of previous surgeries or there's other issues, sometimes you need a traditional incision, a bigger incision where you stay a few days in the hospital. But that would be sort of the standard approach to surgery for endometrial cancer. So for many patients, surgery is all that they need, and a large proportion of patients are cured with surgery alone. Sometimes based on risk factors. So once the uterus and cervix and tubes and ovaries and lymph nodes are all removed, they get sent to our pathologists who look at everything extremely closely under a microscope. Once all of that information comes back, we can tell you exactly what stage the cancer is, and then make recommendations about whether or not any further treatment is required. So sometimes we might recommend radiation, either just in the vagina or sometimes in the pelvis. For patients who have disease outside of the uterus, based on that surgical staging, either the lymph nodes or the ovaries or somewhere else, we might recommend chemotherapy as well, in addition to radiation. And for all patients, regardless of further treatment or not, we typically follow patients quite closely, seeing them every 3 to 6 months for kind of 3 to 5 years, depending on their risk after surgery. So in terms of prognosis or what we can expect, patients with early stage endometrial cancer have a 5-year survival rate of 80 to 90%. So this is like, you know, sometimes I say to my patients, not to make light of what the situation that they're in, but if you could choose to have any cancer diagnosis, if you have an early stage endometrial cancer, you know, for a lot of patients, all that you need is a laparoscopic hysterectomy, and that's it. You're very likely cured. So this sort of drives home the point of why we want to encourage people to seek a diagnosis as soon as they have symptoms, so that we can detect endometrial cancer in its early stage, which we often do, because to be honest, many women are very good, particularly postmenopausal, about going to their doctor right away when they see that they've had bleeding. You know, if you can see this chart, which is a bit smaller, as the cancer advances in stage, like many cancers, we see decreasing rates of, you know, what we call 5-year survival, or what percentage of people are still alive in 5 years. So really, we want to try and catch people in the early stage so that we can cure as many people as possible. So that's all that I had for all of my medical stuff.
That was fantastic. Thank you so much.
Yeah.
Great. Ian, was there any more questions in the chat? Also
nothing,
conscious of time a little bit.
Yeah, nothing else came up from the chat, just that one that we had in there for now. So
awesome. Well, I think this is such an important conversation to have. I think there's more conversation to be had as well, but I think this is a fantastic starting point. I know I had penny drop moments myself, just in hearing your story and understanding more about the clinical side of things. Thank you both for sharing as much as you did. I'm sure we're going to, as I said, have tons of conversation, but I think what I love the most is that at the heart of this, it all comes back to kind of the same thing that we've heard on repeat as well. Individualized care is really important. Knowledge truly is power, as we said in the title of this webinar itself, and that understanding what we live with, whether that's the obesity side, the endometrial shenanigans side of being a person with a uterus, because there's lots of shenanigans when one has a uterus. Really, owning that, getting more comfortable and confident in being able to talk about it, understand it, and push for that level of care that we all really deserve, I think is so, so important. So knowledge, detection, treatment, and connecting with the caregivers that you're working with, and encouraging them to slow down if you're feeling like they're not slowing down enough for you, looking for healthcare allies. So if you need someone to go with you for a pap test because you want to start these conversations, there are people out there. I wish I could go with each one person, but just get them in the room and have the right conversation with the doctor. But even that truly is an option. And as I was saying earlier to Gia as well, just that ability to call a thing can sometimes really help the room come down. So the more caregivers that we can have that understand the complexities of the people they're talking to, and patients being able to go, this is uncomfortable. This is hard to talk about, and I need your help. And I love what that doctor said to you, Gia. We're going to figure this out together. So I know Ian and I talk a lot about, we want to come top down and get these physicians on board, but we also need to bottom up and really empower patients. And the best way we can do that is moments like these. So sincerely, thank you both so, so much for the time today. I'm sure we'll have more questions, more conversation. Please keep your eyes peeled for this campaign as well, and share the knowledge about endometrial cancer with anyone that you know walking around with a uterus, and make sure that they understand that this is a moment, and this is worth understanding, worth talking about. Team IUD for life. All of those moments, there's lots here to talk about, and let's make it really human and easy to talk about as well. Yeah. So thank you everybody for joining today. Ian, was there anything else we needed to say in wrap up? Sorry.
I was just going to wrap up. I wanted to thank both of you, Sarah and Gia, for joining us today. This is something for me that, does hit a little close to home. We had a situation in our family where cancer was diagnosed recently, and if there was an early detection and people were a little bit more comfortable talking about this or asking questions or even just going to see their doctor, outcomes might be very different. And so it is something that hits home, and I'm glad that we're talking about it. So we'll have the recording for this up on our website, and we'll share it widely probably tomorrow. So keep an eye out for that. Share it with the people that are around you, and keep an eye out for future connected conversations.
Thank you so much, Ian. As Ian said, join us in the Connected Conversations area. There is one for the general public, as well as there is a professional one, and we'll be sure to make sure that we share all the resources today. If you have questions, find us along the way as well. We want to keep these conversations going. And with that, I will wish everyone the best. I hope everybody enjoys this new month that we're in the month of September. Be kind to yourself and at least one other person today. Remember to wash your hands and take care of each other. Thanks, everybody.
Thank you so much.
Thank you.
Bye.